cardiology, it might take you a step further. طبعا دائما أنا لما أقول للfellows, whenever you're starting your cath lab rotation, either as a junior for cardiology during your fellowship or as an interventional fellow, you should take it step by step, because that's the way you learn cardiology or interventional cardiology specifically. You will not master everything at once. You have to master little bit of things at a designated time. So the way I usually do it is the first week of my rotation, I just want to focus on mastering the access, be it radial or femoral, and mastering it, meaning that you should know everything about it and how to troubleshoot it. لأنه الcardiac cath lab أو cath lab, it's not difficult. It's actually easy, and as long as you follow the steps and you know how to troubleshoot when you reach a dead block end, you know how to do the alternative. So today's lecture is about vascular
دكتور خالد.
هلا
دكتور خالد ما اسمعك يا دكتور خالد.
سامعني الحين؟
اي نعم، الان رجع الصوت، الله يحفظك.
اذا اوكي انا من اول بتكلم بس ما في مشكله. يلا بسم الله. طبعا هذا الديسكليمر حقي انه هو it's restricted but for only radialist, and because I was trained at the area وكان لسه في debate about radial versus femoral, but the debate is ending خلاص, and we know that radial is better by all means than femoral. However, it's سلاح ذو حدين. You have to know the radial skills, and it's a different set of skills, but also you have to be safe femoral, meaning that you know how to do a safe femoral puncture for different variety, either because if you failed radial access or for large bore intervention. لما احنا بنسوي impella, we need a large bore for inserting our equipment, and also for TAVI and structural procedure, you need femoral access. So the review here today is about just an outline about what we'll talk about radial versus femoral access, the technique, and also the best is to learn it by doing. And I'm just reviewing the methodology of it. And the challenges you're gonna face when you do a radial access, the common complication and some practical tips to how to deal with them, and about the updated guidelines in that regard. You can't start a talk about radial access or coronary angiography without talking about this figure, Lucien Campu. He was an interventional cardiologist in Montreal Heart Institute, where I was trained. He was actually dead when I did my training there, but he has a statue under his name because he is considered to be the reviver of radial access في العالم. في another one, Kemenji, he was also the second wave reviver. يعني في البداية كثير ما يعرف هذه المعلومة. في البداية كان الراديال كان الكورونري angiography done by radial and brachial, and then because of equipment mainly, لأنه التكنولوجي wasn't advanced في ال 80s, رجعوا للفemoral. بعدين somewhat in between the 90s, radial became popular and get back on track and became the default nowadays. So I recommend that anyone to read. This was the study he published confirming that it's easy and you can do it safely for patients. هذا second reviver, Kemenji, I think he's from Netherlands. He has a Twitter account. He's very active. وبعد ما خلص الآن من radial access, because he was the first interventionalist to do a percutaneous coronary intervention via the radial. Campu, he was the first to document that it was safe to do radial diagnostics, but the first one to do it was Kemenji to do PCI, and he proved the concept. And actually there is a story behind his and عادة a scientist, when they invent something, is because they were cornered into the corner of they were forced to invent that way. Who كان شغال في مستشفى, most of their patients were on anticoagulation, Coumadin, IV heparin, both thrombolytics. And the KPI of that hospital was that they had a lot of mortality from bleeding from the femoral access. The manager of the hospital down the primary PCI or percutaneous coronary intervention program because of the complication. So he was thinking outside the box, and he came up with that he used the femoral equipment interradial and used it to do the first PCI, and showed it was safe and actually efficacious. Also, it was actually proven in RCT that it might reduce mortality. There's many ways of using the access for coronary angiography. You can use the radial, and nowadays the big or the new kid in the block is distal transradial. I'm not a big fan of it because it increased the procedure time. Why? But it's good alternative. It's always good to have something in your pocket that others don't have. So if you can do it, do it. It's just a radial, but distal. And usually is they puncture in the anatomical snuff box in the thumb, below the thumb. And they insert the same equipment. They have their own troubleshooting also, and there's a learning curve associated with it, but it's a good alternative. But my default, and most of the people in the world, their default is a radial access. Ulnar access is also good, but you have to remember that when you use the ulnar, make sure that the patient has a radial pulse. Because if you occluded the ulnar, you will end up with an ischemic limb, and then the patient will lose his hands. The ulnar is difficult to puncture. Some interventions do it with ultrasound guidance. The reason is because it's not like the radial where it's lying above a bone where you can feel it. It's slippery. It's under a muscle with the subcutaneous tissue and fat. So it moves. Even when you get it with the needle, it moves and slippery. So it's not for beginners, I'd say. And you really need to anchor the artery before you puncture it. Brachial artery is also another alternative route. However, it's very, very important that it's associated with more complication. Limb ischemia has been reported to be seen commonly with it. You can even close it with perclose or angioseal. However, I usually prefer to compress manually to prevent complication. Subclavian and axillary, we've been using it now also with even for TAVI and impellers, and it can be used also for access to coronary if the patient does not have a normal pathway like radial, or ulnar, or brachial. Lastly, translumbar. It's for interventional radiologists, where they do even access the aorta through that when the patient in the prone position. So we're going to go across some of the anatomy and the access technique and the complication and challenges. So as I mentioned, I wonder if you can see the cursor. So here is the radial lying under the radial bone, and that gives it the advantage of the distal radial. It's usually around here. They puncture this vessel and branch and go into the radial itself. The ulnar, as I mentioned, it doesn't have a bone under it directly. There is a lot of fat and muscle, making it difficult to puncture. And this is just a comparison between the femoral and the artery in terms of size. And even now with better equipment, we can put something called 6 and 7 or 7 and 6 guiding catheter, where you can use a 7 French catheter inside the radial. Because the technology has evolved that now they are making diameter is a 6 French. It's the same as the 6 French. However, the inner diameter is 7 French. It's a bit confusing for some, but yes, 7 French can be used as 6 French because of the inner-outer diameter ratio. Okay. The advantages, again, as I mentioned, superficial cores, easy homeostasis, and very low incidence of vascular complication, as proven with all the RCTs. And the main advantages of making a radial access, it doesn't apply to us here because most of the hospital are not private and they're not in pressure of beds, and the one-night stay is thousands of reals or dollars. Doing a radial in a center where it's overwhelmed with patient is effective in or observing if there is a femoral problem. So it's for the patient privilege, if there is IMSHI immediately, maybe an hour after the procedure, even if it was a PCI. And the other advantage is that it can save costs to the hospital and administration by sending the patient home. And even there is some cath labs where it's a purely radialist and they don't have even overnight team. So by 6 o'clock, everybody's gone and they close that. So they save on the cost generally. The usual checklist that comes into my mind when I do a radial access, and I think you should encourage yourself as a fellow to do it, is by feeling the radial artery, you see the vessel size. Is it big? Even sometimes I went into one in a big guy, an 8 French sheath, where his radial was very big and juicy. And the strength of the bus is a factor. A previous angio also is a factor because about different registered different percentages where it's from 10 to 33% of radial artery occlusion have been documented. However, also in a skilled trained hand, you can even re-access an occluded artery, but not for maybe beginners. The Allen test and its modified variant, should you do it or not? Personally, I don't do it because I don't believe it will change my decision to go radial or not. However, train yourself to do it. I'm sure you're going to be asked about it. It's a knowledge that you have to know. I'm going to explain it in the next few slides. And it's also something that good as a general, and myself, I did Allen testing myself and I actually failed it. I have an abnormal Allen test. I don't have good collaterals. Think twice, but I think I'm going to go radial because I think the morbidity associated with femoral is far more than an abnormal Allen test. The other question that you should ask yourself about is the patient. If the patient is young and he's going to have either or to use a fistula, because damaging the radial artery can maybe hinder his future use of forming a fistula. Also for grafts, I know most of the centers of Saudi might have full arterial cabbage, but the surgeon sometimes use it. So I had a patient who doesn't have radials post he had full arterial cabbage. So you have to know it, and you have to know that learning a distal or an alternative access is important. So the Allen test, as I said, it was described initially by Allen in 1929, modified by Dr. Wright in the mid 20th century. How you do it, there is with the pulse oximeter or without clinical one. The clinical one, you just compress both. And then you ask the patient to pump his hand to pump the blood out. And then you see when the hand is pale, you raise your compression from the ulnar side. And then you measure the time. Less than 5 seconds, it's normal to return to complete red hand. 5 to 10 figure where the patient even take longer time for the blood to come back to the radial circulation, which proves that there's a good palmar arch collateral circulation that can provide the thumb in case of the radial artery occlusion. The other way, which is quicker, faster, and actually reproducible, you can see it, is you attach a pulse oximeter to the thumb of the patient, and then you compress, and you observe after 2 minutes what waveform you'll have. If the waveform is unchanged after a good compression of the radial artery, compression that you want to occlude it, not just feeling it. If it gets dampened of the pulse, then this is a type B. If it gets flatter and flatter, C, where it's completely flat at the beginning and after 2 minutes, then it's a type D. They usually say you can access ABC, but not D. I usually don't look into this. I just go ahead. If there is a pulse, I can puncture it without even risk of complication. I've never had a radial complication so far. There was, as it's known in cardiology, every day we have a question, and every day there's an RCT about it. They studied it. Some said that it is the standard of care. Some said not. The consensus is that if you are working with an obsessive consultant, you should ask him first, should I do Allen test or not? He would know that you know about it, and then he might discuss it with you. For me, I usually just say no, don't do Allen test, just go ahead. If there's a pulse, go ahead, radio. That's my default, because I don't think it will change my management. It's good theoretical knowledge, but not applicable to the patient's care. Sure. Related into a clinical heart outcome. Okay, this is the same study. For the techniques, there are two main techniques that you can use to access the radial artery. First, make sure that you're comfortable. Comfortable meaning either you wanna, it's different lab, different setups. Most of the labs here in Saudi Arabia, I noticed they do it with the patient's hands to the side of his hands. Where I was trained in Canada, they put the hands on like a patient يعني يكون مسدوح ويده على الجنبين. Then we move it after the puncture. I found it more convenient for the operator and for the patient. However, get used to whatever your orientation is. Elevate the level of the bed to the level of your back. Don't bend, because if it's a long procedure, getting tired at the beginning of it is not good for the patient or good for yourself. There is two main techniques for doing it. Actually, third, if you add the ultrasound. The first one is just anterior wall puncture. Anterior wall puncture is you feel the artery side to side, and you roll it with your hands, and then you find the maximum impulse. Some people do it like distal. They put their thumb and index, and then they puncture in between. I usually don't. I just puncture under my maximum impulse, slowly, integrate, until you feel a pulse where the bevel facing the artery, facing the patient. And then gently, once you puncture at 45 degrees, gentle, just change of angle, just a little bit, because you're maybe a little bit horizontal, just of angle to just at about 45 degrees, and then you slide the wire. Never, and that's why I always tell my fellows and residents about it, never push. It has to slide. Interventional cardiology is about, it's a mechanical problem. Pushing is a big no. And when you push, you either stimulate spasm, so you make your second attempt harder if you fail to get into the artery. Number two is you can dissect, and then you lose that radial. So never push against resistance. It should be sliding motion, and you're gonna feel it, and you're gonna learn it, that you would know that I'm subintimal or I'm in the true vessel going into branches or so. After you get the artery, you take the needles, and then you slide the dilator with the sheath. And most of the sheaths now are hydrophilic, which help and facilitate the advancement into the radial artery and reduces the spasm. If you are having, this is tips, maybe it's better on a clinical side, like if you did a rotation with me, I'll show it to you. When you have a difficult radial, either small pulse, there is method that you can augment the pulse. You can occlude distal, and that theoretically will increase and engorge the puncture site, which is probably more proximal. So you occlude distally, and that makes the pulse stronger, so makes it easier for you to fish for that radial. Number two, make sure you injection of nitrate, NTG, nitroglycerin, subcutaneous. Make sure that you're not in the vein or the artery, but it doesn't matter. Even if it hit it, it will not. If the patient is spastic, give subcutaneous. I'm not sure it does work, but I do it, and it worked with it. I don't know if it's that I got it by chance or luck, or it was that the nitrate diffuses into the arterial wall and it prevents the spasm. This is only when the patient, it's not routine, it's only when you have difficulties or when you fail. I'm an engineer fellow, and he's done 5, I usually allow 3, but he's done 5 sticks. Of course, the artery is spastic and it will be difficult. So allow that the hematoma to resolve by firm compression on it. Give some nitrate, that might help restoring some of the radial pulse. It is first described by Seldinger and it was initially for a femoral puncture, and it did, and this is the first paper that he described this technique. It was for the femoral. It's the same application in the radial. There is the angiocath technique. Some people use it as their default. I don't, and I don't think it's of more advantage. Some people are more comfortable with it. Well, because it's you require the angiocath, which is what they use for the nurses for the peripheral IV line, where you go through and through. So you see the pulse, you see the blood getting back into the cannula, and you go through again where the pulse is gone. So, and then you take the needle and simple withdrawal of like millimetric withdrawal of that cannula until you see radial pulse, and then you slide your radial. And actually they did do a study comparing both. Both were efficacious and both are good. And I've used it initially in my training, but then I got so comfortable with the Seldinger technique, and I used it as my default. You can use this or that technique based on your comfort and your training level. Again, for me, I don't like it because it's an extra equipment that you add, and there is that theoretical risk that you are puncturing the posterior wall, but it doesn't matter. Even if you transfix, it will seal with the sheath as being introduced. And the third method, as I said, which is a little bit fancy, but I've used it, and my fellows did see me use it when I really have to go radial. There is no option because the patient is obese, because the patient is on triple therapy, and the patient is on anticoagulation. And difficulty is because with the ultrasound, you're going to see. Also, use this when you're, I think all of us now trained with ultrasound or we're comfortable with it.
المعذرة دكتور خالد، الصوت يدخل ويطلع، يعني في تقطيع في الصوت. إذا في استطاعة نحس والله يعني مو كثير، متوسط أقول، يعني كل 5 دقائق يحصل. فإذا إذا الشبكة، إذا أنت في محل بعيد عن الواي فاي يمكن لو تقرب يا دكتور، أو إذا أنت كويس خلاص شكرا.
ممكن أفضل، بس أهم شيء
الآن يقطع حتى يا دكتور شوي. ما أدري إذا الشباب عندهم اقتراحات في الكومنتس يكتبونها. otherwise نكمل وشكرا.
كيف كذا أحسن؟
كذا كويس يا دكتور، الحين أسمعك.
كذا حولت على شبكة الجوال تبعي ممكن.
أتوقع أسرع بكثير إن شاء الله. الجميع في الكومنتس يقول لك كويس. نكمل. المعذرة عن المقاطعة، تفضل.
طيب. Going back معلش على okay. طيب, ultrasound. As I said, ultrasound is useful, especially when I really want to do radial, and I'm sure all of you are comfortable with ultrasound. And the way to confirm that if you're in doubt is this a vein or an artery, you can just put a Doppler, and if it's an arterial Doppler, then for sure it's radial, and you can wire it. As it is, for the States, they do study for everything. They did show that it can be done, and it reduces your attempt, obviously, in the attempt of accessing, and it doesn't change the outcome. However, it does saves times, because if your setup is with ultrasound, because people would think otherwise, that having to use ultrasound will delay you. No, if you're familiar with it, then it will not, and it will just make it just quick and easy. And even if you want to convert to femoral, it will be ready, because the standard of care now, you should not do a puncture in the femoral, although I break the rule sometimes, is to do it with ultrasound guidance. Quickly, what would be the challenges that will face you on how to troubleshoot them? Spasm, it's the most common and the most annoying, especially in female, being that they have smaller artery, they have anxious personality sometimes, which exacerbate the spasm. It's better to sedate the patient because that's the beginning of get rid of spasm, is making sure the patient is comfortable, pain-free, sleep. If the patient is asleep, he will not be anxious, so their epinephrine level will not be high, and then their spasm will be less. So make sure that the patient is well medicated with midazolam or fentanyl. Make sure that they're on a good dose. A good dose of when the patient is snoring, but still his saturation is good. The use of hydrophilic sheath. I was trained in an area where we had to use sometimes a non-hydrophilic because of cost, but I think all the sheets in Saudi Arabia are hydrophilic coated. So you have to activate it before. So make it wet before you push it into the hands because it activates the layers on the outside of the sheet and makes it easy to slide. Using pharmacological cocktail. I've seen a lot of cath labs here in Saudi Arabia, they don't do that. I do believe in it for so many reasons. First, it works like a charm in dilating the artery for your access. And number two, it makes it easy for prevention of radial artery occlusion, because there is a study that has been shown that giving an NTG at the end of the procedure makes the sheath removal easy, and it prevents radial artery occlusion. The usual cocktail I give personally is 200 microgram of intraarterial NTG, nitroglycerin, and a 2.5 verapamil. Some people use diltiazem, depend on your labs and availability, but I use this mix of 200 and 2.5. Sometimes even I give 5 if the patient blood pressure is okay. And also some, which is okay with me, I'm not objecting, but because of, in the cases of inferior MI where there's RV infarct, they would want to give, they wouldn't want to give nitroglycerin. So they just give the verapamil, so 5 milligram of verapamil. Okay. In severe cases, which I don't think we have it in our formulary, at least at PKUH, the babaferin, which is a very good direct myorelaxant, or the molsidumine, a vasodilator that transform into the body into nitric oxide. So it's a nitric oxide prodrug. The categories, you don't have to know, it is just for studies and just for confirmation of unifying the language between cardiologists. There is grade 1, 2, 3, just for knowledge how severe is the spasm and how you would tackle them. Studies, they did show that using the cocktail, the one I mentioned, 200 microgram of nitroglycerin, with a 5 of verapamil, when compared to placebo, it did reduce the spasm of the artery, and it did improve the patient experience for the procedure. Okay. RAO is a radial artery occlusion. It's one of the most common feared complication, and unfortunately, it's, as I mentioned, from 10 to 33% ratio that it might happen. Although nowadays, أنا بشوفها صراحة very rare post a procedure that I've done. I think the reason is because you're using a better equipment, smaller equipment, and we're more aware of way to prevent it. In the old days, they didn't give heparin for the radial artery, but then a study from Mayo Clinic showed that giving a 50 units per kg, the usual 5,000 units of heparin, not necessarily at the beginning of the procedure, it could be done at the end if the patient is a diagnostic case. Even if the patient diabetic INR, let's say that you have a patient who came for an emergency cath, radial, and he has an INR of 2 or 2.5. I would still give heparin, mainly for the procedure if it's a PCI. And to prevent radial occlusion, you have to give 5,000 of heparin. And there is no difference between giving it intraarterial or intravenous. My default is intravenous because of the patient convenience, because it burns. Heparin burns and can even make the spasm worse. So why should I give it in the sheath? It will not change any outcome of the status of the thrombotic event in the patient radial sheath. So give it IV if you can. there is no benefit of giving it intra-arterial. And this is the study from Mayo Clinic that I showed, that you can see from giving 0 heparin, the rate of occlusion was 77. They reduced it to up to 4.5 when you give 5,000 of intra-arterial heparin. As I mentioned, one of the radial artery occlusion, I've done it myself, where the patient only access was a radial, because the rest was going to be disastrous. The patient has peripheral vascular disease, he's an amputee, he doesn't have a brachial, he doesn't have any good access except his radial, which was occluded. We had to recanalize. There is a way. You have to be skilled and maybe more senior in doing it, but there is a way of puncturing an occluded artery. However, you have to use specialty wires, and you have to use your skills and knowledge in knowing if you're a subintimal or not. But it can be done. It's not dead end if the patient has radial artery occlusion. The loops is also one of the most challenges that you can face. There is steps to do that you can do to overcome a loop, a radial loop. As I said, the equipment are getting better and better, and nowadays the equipment is in our favor. It makes us better interventionalists, because smaller equipment, more slick, more hydrophilic coating, makes the slide of stuff through the radial circulation easier. What you can do is, I noticed that a lot of people do angiogram. I encourage that in the radial circulation. However, don't give a concentrated contrast. It's also painful. It gives cramps to the muscles. It burns the hand. So dilute it. When you are doing an injection local in the artery, try to dilute it if you can, to identify the anatomy. Personally, I don't do routinely, only when I don't know that my wire is free or not going in the right direction. You can downgrade the 035 wire, which is the J-tip, the usual wire that we use for passing equipment. You can downgrade it to Tiramo, the hydrophilic one. However, I have to tell you, it is a dangerous wire. It's actually the perf wire. Almost every time someone used it, they perfed. Either they know it or not, because it's a slick wire, it's a hydrophilic, it will go everywhere. It will dissect and it will perf. What I usually do, which is safe, use a BMW to come across whatever difficulty, either a small, a loop, or whatever, and then put it as distal as possible in the aorta, and then you can pass the guiding catheter or the diagnostic catheter through it with ease, and then you're going to change with an exchange length. The usual length of 435 wire, it's 180, 190. The exchange length is double that, so 300. So whenever you have difficulties in the radial, once you reach the cusp or the aorta, always ask to exchange over a long wire. So you don't start from zero, going back when you exchange from, let's say, the left to the right. Using body wires, you have to be a fighter, but sometimes it's reasonable to switch plans and just go femoral or go left radial or go distal left radial or ulnar if needed. Using a technique called PAT to overcome spasm and to overcome tortuosity has been described. This is just an example. I'm going to explain to you the PAT later on. This is an example of a loop where you can see it's almost an 180-degree loop and turn in the radial artery. You just pass the wire. Sometimes even external twitching of that loop with your hand when the wire is there can untwist and unfold the wire, and then you can easily pass your equipment easily because now it's unfold. Using something called the PAT. PAT is balloon assisted tracking. What you do in this procedure is you have to have a coronary wire, a BMW, a balloon that is usually, the size is based on whatever size you have, whatever sheet size. If it was 5 French, you use 1.5 balloon. The usual length is 15-20 millimeter length. If it's 6 French, you use a 2 millimeter balloon. And the inflation is between 3 and 6. You put half of the balloon inside the guiding catheter and the other half outside, to bathe your way and to make it smooth for your catheter to pass through the whatever, either spasm, tortuosity, or atherosclerosis. It is very effective. And actually, every time I use it, except once, it did fail me, and it didn't because it was too painful for the patient and I had to stop. The reason also PAT technique is effective is to overcome something called the razor effect, where you can see it here. When there is a wire and no balloon, you have like a sharp edge of that distal tip of the catheter that makes it even harmful for the injuring the artery, making it spastic and prevent you from propagating your guiding catheter. When you have a balloon, it just eliminates that. Okay, and that's how it looks like on vitro. Okay, hopefully it's clear. That's
yeah, it's clear.
That's a very spastic artery which went smoothly into the distal radial after doing the PAT technique. PAT is balloon assisted tracking. Okay. Again, when you're stuck somewhere, you can do an angiogram to see where you are, because sometimes that there is a rudimentary, it can give you a smaller branch of the artery, and you can avoid it by then going into the main brachial artery, which is rare cases where equipment wouldn't pass as extension equipment. Okay, torqueability. It's challenging, especially it's not for you guys, because most of you will be trained in a radial environment, so your learning curve will get higher. It was mainly an issue for people who were حتى الآن بشوفها. We have senior interventionalists. They don't know how to do radials because it's too you can't teach an old dog a new tricks, as they say. I mean, at some point of your life, maybe learning a new technique would be not cost effective because it's a new skills and it's a new method that you're not comfortable with. The reason that the radial artery is difficult, specifically the right radial, which is the default, is that there's a lot of points of resistance, mainly at the right subclavian and at the entry with the aorta, which makes the torqueability easy. And one of the most common problems that faces fellow, it did happen to me when I was a junior fellow, and it will happen to you, hopefully not as frequent, is over torque that lead to kinking of the wire, especially with the guiding catheter, not the diagnostic. The reason is that you get excited, you get overwhelmed and pushed maybe by your staff that do it quickly, and you torque, and then you kink it. Kinking is one of the worst things that can happen to a sheath. And if you identify it, you say it. Tips include that suddenly you lose pressure waveform and the screen, and that gives you a hint that you torqued. The reason I don't like kinking is, and the kinking happens because of this area of resistance in the right radial. Because it adds a lot of effort and time to the procedure that wasn't, its prevention is the key for kinking. Because once you kink, sometimes even you dislodge it completely, and then you have to snare it. It's a long procedure. Personally, I've done it, and I learned how not to do it. So that's what my advice for you: learn how to not do kinking. If you think you're over torquing, stop, take your time, allow for the catheter to transmit your torque. Some people don't know that. Like I see fellows, especially with the RCA, which is more challenging in intubation and when compared to the left, which is easier, they torque and they want immediate. There is a time. Allow the torque to transmit from the shaft of the catheter into the tip. It will take a few seconds delay, so allow it to shift. Not immediately when you turn. خلاص إذا ما صارت instant turn, there is a problem, so you turn more, and then you overshoot or you kink. So allow time for the transmission of torque across. What I usually do is with my left hand I torque and I transmit with my left hand. And hopefully يعني هذه ما أقدر أشرحها أكثر. ممكن when you do a rotation with me I'll explain it to you. Left radial is better in terms of resistance because it's only one area of resistance, like the femoral, which is only one area of resistance. That can make it less difficult for the people who do these procedures. Complications: hematomas, 1 to 3%, but the major is radial artery occlusion. It's not catastrophic because humans have a very enormous network of collateral that can prevent distal thrombosis and then end-edge thrombosis. Infection, if you don't apply, if you coughed or if you're not using sterile technique, then it can happen, but extremely rare. Pseudoaneurysm, it can happen specifically if the patient is hypertensive or on chronic anticoagulation, because these two can, or they didn't do good compression with a TR band. Maybe they took it too early. Maybe the patient wasn't compliant by moving his hand and dislodging whatever hemostasis happened. That can happen into pseudoaneurysm. Most of the time, the pseudoaneurysm can be resolved by compression. However, if the neck is more than 3 millimeter, an injection of thrombin can be done with ultrasound guidance. I did a couple, but I think interventional radiologists can help us with this if it happens. AV fistula, it's rarely that can happen. The radial artery, more common in the femoral. Retroperitoneal bleed, 0%. However, this is only related to the radial artery. But if you give anticoagulation for the patient, then no. There is reported cases of spontaneous retroperitoneal bleed. So don't rule it out of your equation if the patient is hypertensive post heparinization for a procedure or PCI, that he could have a spontaneous retroperitoneal bleed, specifically if there is signs of that. The hemoglobin is dropping and he's hypotensive and all are normal, like ECG is normal, there is no ischemia that can explain the patient hypertension. Rarely perforation. The radial artery is our friend. Even if it perforated, slide, like I see a lot of people do angiograms. Initially, yes, it was justified because we're exploring the radial arena, but nowadays, I don't advocate for doing radial angiograms because once you see a perforation, it doesn't change my management unless the hand is expanding, then maybe. Advancing the seal and the sheath across that perforation, advancing the radial, the guiding catheter will seal it itself, even if the patient is full anticoagulation. Because it's been shown that when you do perforate at the beginning, where the wire is distal, and then carry on with your procedure, at the end of the procedure, they do a control angio, the perforation is gone. As I told you, the radial is our friend and it seals. That seals by the tension of the sheath. That is just putting an outward tamponading effect and preventing the perforation from staying. Most of the sheath here, it's 11 centimeter length. For perforation that is distal, I would advocate to use the longer one, the 30, which has been shown in some study that it's good for even radial artery spasm because it just delivers your equipment directly to the brachial artery, the distal tip. However, I don't see it available in, at least in my lab in KTUH. We don't have the long radial sheath, but it's very effective and it should be available because it reduces the radial artery spasm and it can help because the distal end of the sheath is in the brachial artery rather than the radial. Dissection and hematoma and the compartment syndrome, it's the most feared complication actually among all this. The most that can scares me, the complication that makes me wake at night thinking about the patient is compartment syndrome. The compartment syndrome, it's because, as you know, it's an enclosed compartment, it's fascias in the muscles. If it bleeds into an area where it's compartmentalized, then it will not expand and it will just stay there, reducing the perfusion pressure, causing ischemia, causing less perfusion and necrosis and death of that muscles and death of that hand. So recognition is important before it's prevention, but recognition is also as important. You have to have a trained nurse to know when the hand is expanding. Once actually I was doing it in not in Saudi Arabia, in a charity work outside the kingdom, and the patient had like تعرفوا باباي يده صارت زي باباي. من الانتفاخ الهيماتوما. Nobody recognized it. الرجال كان جالس فوق وكان يتعشى وعادي يعني الوضع في السليم. لكن when I saw it, it was so scary because first, this is the biggest hematomas I've seen in my life. Number two is that there is, I'm sure that there was a compartment syndrome. Number three, that there is no vascular surgeon on site that can help us to evacuate that fascia or that hematoma underneath the fascia. What you can, this is how it looks after the fasciotomy. It's very ugly, but it can save the hand. The recognition that the patient usually loses sense, neurological problems, then followed by maybe loss of pressure and loss of pulse on the pulse oximeter, and you can even see that there is signs of ischemia distal, change of color. The orthopedic, I think, and plastic surgeon are the one who does these procedures. They have an intra-compartment pressure. They measure, they verify the diagnosis, and it's an emergency. They take the patient to surgery to do fasciotomy to relieve the pressure. However, what happened to me there, زي ما قلت لكم, I googled how to do fasciotomy في YouTube, how to do it in case I need to do it, because the patient will lose his hand. What I did is this, so inflate the pressure, and this is a conservative, it can work, and it did work in my case. Inflate the pressure, the cuff, if it's small, if it's not, just bring a Band-Aid that is, roll it around the hematoma, inflate it 15 millimeters of mercury below the systolic pressure to allow at least an integrate flow, and at the same time you're compressing the hematoma. Hopefully it diffuses somewhere that it relieves, and stop all the anticoagulation if needed. If the blood pressure is high, give it something to lower it, because lower blood pressure, lower tension, lower escape of that perforation. And this is how you do it. Pulse oximeter, make sure that the patient has distal flow, and you just inflate it 15 millimeters below the systolic. And the perforation is just the knowledge to know, and this is how it looks before and after the procedure, when you carry on and do even a PCI without problem. Dissection flap. Most of the dissection flap that can happen is a favorable dissection because it is against the blood flow, so it will seal. However, if the dissection in the other way, then it's not. It has to be stented. So most our dissection that we cause in the radial artery is retrograde. So the flap is retrograde. The flap is behind the flow. So it is not a big problem because the pressure itself will seal it. With time, it will just heal with either a stenosis or it will heal completely when the hematoma resolves. So because if the dissection flap in the other way, it will never close. And then you might think about either surgery or stenting if possible. Sometimes for big perforation that did not seal, I've never used it. I've never seen the colleague that used it is using a cover stent, a coronary cover stent that can seal a big perforation or a rupture. There is other problems, which is, I didn't mention it here because it's really high-end stuff that can maybe complicate things. Radial artery entrapment, I don't see it often now with the hydrophilic sheath. However, I've seen radial artery avulsion secondary to radial artery entrapment, where the radial sheath, when you remove it, it is so attached due to spasm that you avult the artery out of it. And there is picture, you can Google it, radial artery. It's very horrific, where you take the radial artery out of the patient when you pull too hard. So don't pull too hard because there is technique. You can put warm compressor, you can inflate the pressure cuff for 10 minutes and then inflate it for the reperfusion, can produce nitric oxide that can prevent the attachment or the entrapment of the radial sheath. You can also sedate the patient deeply, because if it's due to anxiety and patient awareness, deep sedation with propofol, you can call anesthesia to deeply sedate the patient, can help relieve that, but don't pull too hard. If you pull too hard, you will avult the radial, and then you convert a small problem into a bigger problem. This is the timeline of the big studies that did study the radial artery across the years and did show benefit across quickly because it's not the area for it, and it did show the consensus of all these studies that it was safe and effective. It will not hinder your PCI. It will not make it difficult. It will not make it. It will not increase its failure, even in complex procedure CTO. That I do it by radial sometimes. It doesn't make the success rate less. Yes, it makes it. Sometimes it's annoying when the guiding catheter it's not sitting in the place. It is requiring a lot of patience, but it does not change the success rate of the procedure. It's actually in the contrary. It does improve the patient outcome by comfort first, إنه المريض يقدر يمشي بعد البروسيجر. Number 2, prevent vascular complication. All this being said, it is important to know the femoral axis. Why? Because the femoral axis is your safeguard. You can't insert a balloon pump in the radial. You can't insert an impeller in the radial. You can't do TAVI in the radial. So you have to learn femoral. So take the advantage. لأنه في paradox بيسموه the Barbu paradox. That we got too good with the radial that we forgot our femoral. It's been debunked by a lot of radialists في الارena وقالوا لا ما يأثر, there is a study to prove it. However, make sure, because if you never done femoral, you will never do it. And actually, I see it with my colleagues. Luckily, أنا كنت peripheral fellow, structural fellow, chip fellow. I did a lot of femoral. Make sure that you take the advantage. And if you're in busy cath lab, please لما نشوف أحد يسوي femoral قول له ممكن أجي معاك أشوف. تعلم the technique, learn it, because it will be your safeguard. You can't be a competent interventionist if you have poor femoral skills, because if you stick too high, that's a mortality. That can kill the patient without you knowing or with you knowing. So you have to be a good femoralist. Quickly running through the studies that show that even reduced mortality, reduced transfusion, all in favor of radial artery. Even they studied in STEMIs, and it did show that it's actually a very good, because we give a lot of anticoagulations. It's a very good option. However, there is some people who were against it. They were arguing that you can affect your skills in femoral, as I mentioned, but it does not. And some people even advocated that sometimes it was published in the stroke journal, that using radial increases the risk of stroke. And there is religious people behind it. And شوف هو في influence of industry, influence of big names in. And then you can't teach an old dog a new trick. Societies اللي كانوا, or the people who are against it for a reason. عشان they don't want to learn it. Number 2, there is an economy behind it. Some other hospital مثلا زي اللي في أمريكا, there is industry قايمة على an overstay of patients in the hospital. لأنه they charge the insurance, they take money, هذا money can pay bills. فلما أنت سويت لي radial, we lost this business or revenue. So there is a reason. يعني some people fight for unscientifically or scientifically, like this argument, for a hidden agenda. A hidden agenda is to because they're happy with it. يعني they're making money. جانا هذا واخترع لنا radial artery access. All my revenue from the femoral axis is gone. فليش أنا I adapted. ولو تلاحظوا إنه في until now there is a debate في أمريكا between radial and femoral.
لكن في المقابل دكتور خالد، في المقابل دكتور خالد تشوف ان في الان راديال سويتس، يعني المريض حتى ما يجلس على السرير
بالضبط، لانه
يجلس على كرسي ويخلص بسرعه والمريض اللي بعده. فيعني ايضا في
بالضبط there is a catch-up now يعني الاندستري realized that الاندستري realized that وقالوا خلاص ليش ما نفتح راديال سويت. يعني الكونسبت اوف راديال سويت is being يعني popular. في كندا it's all radial default، ما في احد يسوي femoral. حتى الاولد جنريشن interventionalists they felt ashamed they learned it. صراحه هنا في السعوديه الاولد جنريشن يعني البيج نيم صراحه اللي اشتغلت معهم they don't do radial which I felt sorry. once a patient يعني في البرايفت جاني قال لي ما ابغى الدكتور فلان يسوي لي البروسيجر لانه هو قال لي ما يسويها الا femoral. It was an easy case for me لانه I'm trained radial. It was an easy money for me too يعني I did it. I'd recommend On the other hand, it's all in favor of radial. It's a class 2A for the American because of the politics, class 1 for the European, based on the evidence and multiple RCTs. The radial artery is by far safe. However, femoral is good. There is a volume 2 of this lecture about femoral access. I think we spent enough time for it. Hopefully it was useful, and you learned a little bit of some of the knowledge about radial access. Maybe in the future we can organize a femoral access technique, because again, I believe that femoral is a skill that you have to acquire and a skill that you have to do, and it will help you to become a competent, better interventionalist. Questions?
الله يعطيك العافية دكتور. فعلا this was a good talk, لأن a lot of the F1s have contacted me and said that they haven't been exposed to cath because of COVID-19. And I think that this was a good start to let them learn about cardiology and intervention in cardiology before going back into work. Thank you very much. وجزاك الله خير. وquestions يا الشباب اللي عنده سؤال ناخذ واحد. الشات ما في أسئلة، لكن إذا في أحد الآن عنده سؤال تفضل. مشكور.
عرفوا بنفسكم واسأل السؤال. حياكم الله. أنا عندي
يبدو ما في أسئلة.
اي والله تعبناكم للساعه 9:30 يعني فاكيد.
لا يا دكتور الله يعطيك الصحه والعافيه. وش صار على الرجال حق باباي هذا ابو يد باباي؟ طاب؟
لا الامور صارت كويسه، ما صرت فاسكولار سيرجن.
دكتور خالد.
How to do fasciotomy.
تفضل.
I have one question regarding anticoagulation. If the patient came with
مين معايا؟
محمد الأسمري من كينج فيصل هوسبيتال.
كينج فيصل فين مكانه؟ فين؟
في الرياض.
كينج فيصل سبيشالست هوسبيتال. حياك الله.
الله يبقيك. لو كان الINR so much high يعني what can we do؟
إذا كانت emergency.
Yes, emergency وجاي INR 3-4.
I give heparin. حتى البي سي اي I would not rely on the INR. يعني ممكن الINR يكون اصلا coagulopathy that is not therapeutic. Ideally in an ideal world طبعا اذا كانت elective you wait let the INR drift. لكن في الامرجنسي you give dose of heparin. إذا كنت خايف إذا المريض has obvious bleeding like he's bleeding from his gum, don't give or give half dose. بس أنا الصراحة الروتين what I was trained والevidence إنه you have to give it to prevent occlusion. لأنه having an INR of 2 does not protect. حتى لما you want to stent you don't keep the patient on just an INR because we monitor ACT which is affected by heparin. Okay.
يعطيك العافية. شكرا.
الله يعافيك.
يعطيك العافية. شكرا. تفضلوا أي سؤال ثاني؟
Yes, I'm Dr. Khalid from Medina Cardiac Center.
حياك الله.
الله يبارك فيك. I want to take just your opinion from your experience regarding sometime we are using Judkin right to engage the RCA and the catheter accidentally jumping to the left main. In such case, can we proceed to inject left system with Judkin safe or not?
Why not? If you are coaxial and there is no waste of contrast, then what annoys me most, I'd had another lecture engaging the left main. There is different schools and there is guidelines on how to do it. But if you got a good grip of the ostium of the left main and a good injection, meaning that there is no cusp fluid, there is nothing getting out of the contrast, it's all filling the left system, then go ahead. يعني هذا الكونسبت حق المالتي بيربس والكاثيترز اللي تستخدم للرايت والليفت زي التايجر, which I don't advocate for and I don't like. I'm a pro Judkins left and pro Judkins right because I think it was made for a reason and a good quality. It does not waste contrast. It does not harm the vasculature. A few people does it with multi-purpose. I'm not saying that they're wrong, but that's not the best practice because they do use a lot of contrast. They do use a lot of funky position of the multi-purpose, for instance, to engage. Sometimes they're not coaxial, they are on the tip or the roof of the artery, and they can dissect. Even if there is the side holes. Side holes, something you have to learn about side holes. Side holes gives you false reassurance. It gives you sense of security, but it's not secure. You can dissect with side holes. بالإضافة لأنه side holes waste contrast لأنه some of the contrast will go into the aorta and the side holes. بالإضافة لأنه multi-purpose specifically can slip. يعني أنا شفت a lot of studies, a lot of angiography done by multi-purpose. At the middle of the injection, because of the pressure of the injection, it slips and it goes out, and then you're back to square one. Why the headache? Just do Judkins left, Judkins right, and اشتري دماغك على قولتهم. I think it's better to use the Judkins. However, if you're comfortable with a technique, use it as long as it's safe and you follow the rules. And even if the Judkins right got into the left main, coaxial, and a good grip, do the injection. Any question?
السلام عليكم دكتور خالد.
هلا نواف. هلا.
هلا. سؤالي بسيط يعني الآن احنا مثلا نستخدم اللوكال انستيزيا، مثلا هل ممكن استغني عنه مثلا بدل اللوكال انستيزيا اعطيه مثلا سيستميك مثلا ميدازولام ولا فنتانيل؟
لا
علشان يعني الستريس يكون اخف للمريض.
انا عرفت انت عنيف يا نواف. لا you have to give local anesthesia. وانا الصراحه اللي كنت استخدمه في كندا كنت استخدم الهايبوديرمال نيدل حقت الانسولين. I inject with it حتى المريض ما يحس بالنيدل. لكن give them a local, it's very painful. next time ممكن I work with you I'm gonna يعني ادخل radial puncture في your hand without anesthesia and tell me how you feel. It's painful, so you have to give. Okay.
دكتور خالد ممكن أسأل سؤال؟
تفضل. مين معاك؟
معك سمير كينج في هذا ميديكال سيتي. There is a case post radial approach. There was digital infarctions bilateral both hands and with loss some fingers. Is it common to face like this? A complication post scan?
Digital. Oh my God, this is extremely rare. I would investigate the reason. It's probably due to microemboli rather than a local problem to the radial artery. لأنه زي ما قلت لك radial artery vasculature is very very rich and the collateral develop within seconds. I don't think it is. I don't know the exact details of that case. لكن إذا كان مثلا مريض peripheral vascular disease and he doesn't have an ulnar and he has only radial and then occluded, then it might be the case. But in general, I've never seen it صراحة in my experience. But it can happen, yes, theoretical. But I think that if it was multiple digital, this كانت في التريتوري حقت الراديال ولا الأرنر؟
both hands and
yeah. So if you said both hands, then it's probably an embolic phenomenon. لأنه why would a local problem goes into the left to the other hand, صح? But then probably it's an embolic phenomenon. ممكن المريض عنده a fib و he showered the clot and it went into the hand. Probably it's a systemic problem.
Actually, we screen for her for all systemic issues, for all systemic vasculitis, nothing proven. And patient it was a normal sinus, and I have the pictures of she lost about 3 fingers bilaterals, and we did for her plastic surgery.
So both hands. والله yeah. You should write it صراحة. This is a good case for discussion or present it. لأنه for me, I think it's systemic problem, or ممكن المريض يكون scleroderma and she has a vasculopathy, and then
she had renewed after the procedure both hands. Also.
Okay, so she might have an underlying vasculopathy that predispose her to it. But I don't think itself the radial or the radial axis or the radial artery occlusion that caused it. يعني إذا سوت femoral, she might have it. She's unlucky, but it happened.
Okay. Thank you so much, Dr. Khalid.
Dr. Khalid, one more question, please. I think Dr. Sharuk has a question also. For me, my question is, I've met a few people who have experienced neuropathy after radial artery puncture. My question is, how common is that, and is it permanent? Will they feel like numbness خلاص forever, or is there a treatment for that?
Wallahi, it's a good question and difficult because I don't know the answer, and it's not described as a common side effect. However, there is a radial artery, a radial nerve that runs close to the radial artery, so you can have it. I don't think that there is treatment because if it's a damage, it's a mechanical problem. So it's mainly physiotherapy and just neurology consult and medication to relieve the numbness, like ايش اسمه الدراج اللي يعطوه الدايابيتك؟
بريجابلين مثلا او
جابابنتين والادويه هذه can help, but it's not common. I don't I've seen a lot of redos and I've seen a lot of patients who got it. Got radial access without this complication, but it can happen obviously. The radial nerve is around the area.
Yeah,
that's one of the benefits of using ultrasound. That's one of the benefits of using ultrasound.
Yeah. Avoid nerve injuries.
Exactly.
Yeah. One more question in the chat from Dr. Sharuk. She asks regarding heparin as part of the cocktail in acute STEMI. Patient usually receive heparin at the ER. Do you give it again in the cath lab?
لا إذا المريض أخذ heparin في الإمرجنسي
5000 heparin في الإمرجنسي
5000 في الإمرجنسي وكان during my puncture ما لأنه أحيانا يكون انعطى بس انعطى قبل ساعتين فالإفكت حق الهيبرين راح.
نعم.
You have two ways. أنا technically most of these cases it's a STEMI, so they will definitely need extra.
صحيح.
Which is another point. صح أنا نسيت أذكر لكم إنه you have to give I give the heparin after I cross the arch. لما الواير حقي يوصل للروت I give the heparin. عشان in case I convert into femoral, I don't want to convert when the patient is heparinized. That's another trick. But going back to the question, no, if it's quick, just half an hour ago they give him, then I don't give it, especially if it's a diagnostic. But PCI you'll give anyway, guided by your ACT. Or you can just simply, once you have the radial sheath, you withdraw blood, give them for ACT. If it's below 200, 250, then you give extra 2,000-3,000 according to the body weight of the patient. But you can just rely on the 5,000 alone. It could be enough, or you can give extra.
It's clear now. يعطيك العافية دكتور وشكرا لك تواجدك وإن شاء الله نشوفك في محاضرات قادمة بإذن الله.
الله يعطيكم العافية ونتمنى أن استفدتوا منها.
يلا في أمان الله يا جماعة، مع السلامة.
مع السلامة.